what are the causes of hypokalemia in ischemic heart disease patient? Acute MI or ischemic cardiomyopathy, heart failure, cardiogenic shock. Ischemic heart disease patient, what are the various causes of hypokalemia? We should know all the causes of hypokalemia. We have 2 cases of hypokalemia. We will discuss the second case. We should know all the causes of hypokalemia, and we should know the flow chart and how we should approach in a patient with hypokalemia, and then treatment. What are all the causes of hypokalemia? Suppose if you take hypokalemia, there are only 3 mechanisms, 3 important mechanisms. For hypokalemia, either decreased intake of potassium or redistribution. Redistribution means potassium entry into cells. Conditions causing shift of potassium into cells, that is redistribution, or increased excretion. Decreased intake, redistribution, and increased excretion. And intake, redistribution, excretion, simple. So decreased intake means malnutrition, starvation, or in pediatric patients clay ingestion. Basically starvation, malnutrition, clay ingestion. Suppose if a 75-year-old patient, malnourished patient, if he develops ischemic heart disease, we should look for a decreased intake part also. That is one, decreased intake. Second one is most important one, redistribution. So in what condition there will be shift of potassium into cells? Further, do you remember AHA? There are 3 conditions, AHA. First one is A is metabolic alkalosis. In metabolic alkalosis, there will be hypokalemia. Hypokalemia causes metabolic alkalosis. Hyperkalemia causes metabolic acidosis. So metabolic alkalosis causes hypokalemia. So what is the underlying mechanism? We should know the various enzymes. Okay, hydrogen potassium ATPase. Hydrogen potassium ATPase enzyme. In alkalosis means less number of hydrogen ions. Alkalosis means less number of hydrogen ions. Then with the hydrogen potassium ATPase action, so more hydrogen ions, they come out of the cell. So will be more potassium entry into the cell. With the action of hydrogen potassium ATPase in alkalosis, less number of hydrogen ions. So more hydrogen ions will come out from cell and potassium will enter into cell. So that is because of hydrogen potassium ATPase action. So in acidosis what happens? There are more hydrogen ions in serum in acidosis. Then hydrogen enters into cell. Potassium will come out of cell. That causes hyperkalemia. So usually metabolic alkalosis will be associated with hypokalemia. Acidosis is associated with hyperkalemia. The main mechanism is HK ATPase, hydrogen potassium ATPase. So second day patient developed significant hypokalemia. So immediately we should do ABG also at that time. We should do ABG. We should look for other causes of acid-base disorder. Okay. So in diarrhea, what is acid-base disturbance? Diarrhea can cause hypokalemia. So what acid-base disturbance you expect in diarrhea? In diarrhea, metabolic acidosis, because there will be a bicarb loss. Below the ligament of Treat, the gastrointestinal loss is bicarb loss. There is loss from stomach and duodenum, there will be HCl loss. HCl loss will cause metabolic alkalosis. So pancreatic secretions or small intestine, gastrointestinal, diarrhea will cause bicarb secretion, bicarb loss and potassium loss. So bicarb loss causes metabolic acidosis. Okay. So in this patient, a congestive cardiac failure patient, second day developed diarrhea, that will cause hypokalemia. But immediately we should check for acid-base disorder also. The patient has metabolic acidosis or not. So what are other conditions that can cause hypokalemia in a cardiac patient? We should know whether the patient is using diuretics or not. Diuretics. What diuretics can cause hypokalemia? The loop diuretics, thiazide Loop diuretics, thiazide diuretics can cause hypokalemia. Only potassium sparing diuretics will cause hyperkalemia. Should know whether the patient is using Lasix, loop diuretic, or thiazide diuretics. So patient is not on diuretics. So coming to the causes, one is decreased intake. Second one is redistribution. Redistribution, A, alkalosis, metabolic alkalosis can cause hypokalemia. H means hormones. What hormones can cause hypokalemia? One is insulin. Insulin, beta-2 sympathomimetic activity, beta-2 sympathomimetic drugs. Beta-2 sympathomimetic activity means any acute care setup increases catecholamine levels. So acute myocardial infarction can cause the transient hypokalemia by releasing catecholamines. So alcohol intoxication or acute MI, head injury. So any condition causing increased catecholamine levels can cause transient hypokalemia. That is increased beta-2 sympathomimetic activity. So beta-2 sympathetic drugs means bronchodilators. If patient is on bronchodilators, that can cause hypokalemia. Or tocolytic drugs, ritodrine, they can cause hypokalemia. So here, what is the underlying mechanism? Insulin can cause hypokalemia. But what is the underlying mechanism? Diabetic, okay. That insulin can cause hypokalemia. Even increased catecholamine release, stress catecholamine release can cause hypokalemia. If we give methylxanthines like theophylline, then that can cause hypokalemia. Other causes are even thyrotoxicosis, thyrotoxic hypokalemic periodic paralysis. Even thyrotoxicosis can cause hypokalemia, again by increasing catecholamine levels. Or beta-2 sympathomimetic drugs, agonists, so alpha antagonists. Alpha antagonists can cause hypokalemia. The basic underlying mechanism is sodium potassium ATPase. They increase the action of sodium potassium ATPase. So what is the action of sodium potassium ATPase in a cell? Sodium potassium ATPase. 3 sodium will come out of the cell. 2 potassium will enter into the cell. So during depolarization, sodium will enter into cell. So after depolarization, sodium will come out of the cell by the action of sodium potassium ATPase. 3 sodium will come out of the cell, 2 potassium will enter into the cell. So conditions increasing sodium potassium ATPase activity will cause hypokalemia. Okay. Insulin will increase sodium potassium ATPase activity. So beta-2 sympathomimetic activity, sympathomimetic drugs, all will increase sodium potassium ATPase. Thyrotoxicosis will increase sodium potassium ATPase. Okay. Any downstream stimulation of sodium potassium ATPase, like with theophylline, caffeine, all can cause hypokalemia. Alpha antagonists. Okay. These are the causes of hormonal causes of redistribution of hypokalemia. Here redistribution means total potassium is normal, but there will be shift of potassium into cells. That is redistribution. There will be shift of potassium into cells. That causes hypokalemia. So there will be transient hypokalemia. So other causes. So first one is alkalosis. Second one is conditions increasing stimulating sodium potassium ATPase activity. Third one is anabolism. If there is significant anabolism, like if there is increased RBC production, if we give folic acid and B12, for anemia, there will be increased RBC production. If there is increased RBC production, the cells will utilize potassium. There will be utilization of potassium by the cells. That can cause hypokalemia. or if you give CSF, granulocyte monocyte colony stimulating factor for WBC production, even that can cause hypokalemia, or total parenteral nutrition. So whenever there is increase in anabolism, increase in production of RBC or WBC or total parenteral nutrition, they can cause hypokalemia. The cells utilize more potassium. More potassium will enter into cells. The other causes like pseudohypokalemia, even hypothermia, in familial periodic paralysis, or leak channels. If there are leak potassium channels are affected, like in barium toxicity, they also can cause hypokalemia. These are the causes for redistribution. Regarding redistribution. Okay. Third one is secretion. Increased potassium secretion, that is renal or extrarenal. So what are the extrarenal causes of potassium secretion? Extrarenal loss of potassium. So loss of potassium can be extrarenal and renal. Extrarenal means a GI loss, gastrointestinal loss or integumentary loss. So through sweating or GI loss. Here in our case there is diarrhea. 4 to 5 times diarrhea. The diarrhea can cause hypokalemia. So extrarenal loss and renal loss. What are the conditions of renal loss of potassium? So one is increased solute or salt delivery into distal tubule. Whenever there is increased salt delivery into distal tubule, so the glomerulus, the descending loop and ascending loop, proximal tubule, proximal convoluted tubule, and descending portion and ascending portion. In ascending, the thin ascending portion, thick ascending portion. Here it is distal convoluted tubule, DCT. The structures: proximal convoluted tubule, descending limb, ascending limb. Ascending limb thin, thick, then distal convoluted tubule, followed by connecting ducts. Connecting ducts and collecting ducts. Distal parts are connecting and collecting ducts. So what are the mechanisms of hypokalemia? So one mechanism is increased solute or salt delivery to distal tubule. Increased salt or solute delivery. So what is the aldosterone action? Where is the action of aldosterone? In the collecting ducts, aldosterone action is sodium entry into the cell and potassium hydrogen secretion. So aldosterone action is, mineralocorticoid action is sodium entry into the cell and potassium hydrogen secretion into the lumen. So if there is increased salt delivery, there will be sodium retention. The sodium retention will cause potassium secretion into the lumen. That will cause hypokalemia. So whenever there is increased solute or salt transport into the distal part, there will be sodium retention and potassium secretion. Like in with the diuretics, loop diuretics act on which part? Loop diuretics act on thick part of the ascending limb. Loop diuretics act on thick part of the ascending limb. There are NK-CC channels, NK2CC channels. Sodium, potassium, 2 chloride, NK2CC channels. So loop diuretics inhibit NK2CC channels in the thick part of the ascending limb. So in the thick part of the ascending limb, there will be sodium absorption, potassium absorption and chloride absorption. Loop diuretics inhibit the channel. Then there will be more sodium entry into distal part. So there will be natriuresis. More sodium entry into distal part. Here there will be, because of aldosterone action, there will be sodium retention and potassium secretion. So loop diuretics acts on this part. So there will be sodium and potassium secretion. Again more sodium entry into distal part. There will be aldosterone action. Again there will be more sodium entry and potassium secretion. That is the mechanism of hypokalemia and loop diuretics. Thiazide diuretics, where they act? Thiazide diuretics act on distal convoluted tubule. They act on NCC channels, sodium chloride channels. So sodium chloride channels, there will be sodium absorption and chloride absorption. But thiazide diuretics inhibit the NCC channels. So there will be natriuresis. So more sodium enters into the collecting ducts. More sodium entry into collecting ducts. With aldosterone action, sodium enters into cells, potassium is secreted. So loop diuretics and thiazide diuretics both will cause hypokalemia. So diuretics are osmotic diuresis. We give mannitol, glucose or osmotic diuresis because solvent drag effect. With mannitol, if we give more mannitol, this mannitol causes secretion of potassium and hydrogen. That is through a solvent drag effect. So osmotic diuretics and diuretics are salt losing nephropathy. There are many salt losing nephropathies. So there will be natriuresis. So when more sodium enters into the distal part, potassium secretion and hypokalemia. So conditions causing increased solute or salt transport into distal part. With the diuretics, osmotic diuresis or salt losing nephropathies. That is one mechanism. The second mechanism, conditions causing mineralocorticoid excess. So increased aldosterone levels. What are the conditions causing mineralocorticoid excess? One, primary hyperaldosteronism, the aldosterone producing adenomas. Primary or unilateral hyperaldosteronism, idiopathic or secondary hyperaldosteronism, or malignancy, adrenal carcinoma, or genetic causes, familial hyperaldosteronism type 1, 2, 3, or congenital adrenal hyperplasia, or secondary causes of hyperaldosteronism. Secondary causes means with malignant hypertension, hypovolemia, renin secreting tumors, renal artery stenosis, all will cause increased aldosterone levels. Even in Cushing syndrome, cortisol will act on, cortisol has mineralocorticoid activity. Bartter syndrome, Dietelmann syndrome. What is the mechanism in Bartter syndrome? Dietelmann syndrome. Bartter syndrome inhibits NK2CC channels in the thick ascending limb, just like loop diuretic. In Dietelmann syndrome, it acts on distal convoluted tubule. It inhibits NCC channels. Okay. So these are the causes of increased mineralocorticoid activity. Or there is one condition called apparent mineralocorticoid excess. Apparent mineralocorticoid excess. But same syndrome of apparent mineralocorticoid excess. There will be inhibition of 11-beta hydroxynase. 11-beta hydroxynase inhibition. That can be genetic inhibition, as in same syndrome of apparent mineralocorticoid excess, or inhibition of 11-beta dehydrogenase by drugs. Do you have any idea of drugs? Drugs inhibiting 11-beta dehydrogenase? Licorice. The classical drug is licorice. Glycyrrhizinic acid, glycyrrhizinic acid, carbamazepine, licorice, some food additives, tobacco, There are drugs that inhibit 11 beta dehydrogenase. That can cause that as mineralocorticoid activity. Liddle syndrome. Liddle syndrome. ENaC activity. There will be increase in ENaC activity. ENaC channels are activation of ENaC channels. Then sodium retention and potassium secretion. What are secondary causes of hyperaldosteronism? Hypovolemia. Hypovolemia can cause increased aldosterone levels. Hypovolemia, even vomiting, nasogastric suction. Vomiting, nasogastric suction. Why vomiting causes increased aldosterone level? Vomiting can cause hypokalemia. Suppose if that patient has vomitings for 1 or 2 days, even that can cause hypokalemia. In this case, there is diarrhea. Suppose even vomitings can cause hypokalemia. How vomitings can cause potassium loss? What is the potassium loss in vomitings? How much potassium is lost in vomitings? How much potassium is lost in stools? For one stool, how much potassium is lost? For normal stool. For normal stool, there will be 5 to 10 milliequivalents. 5 to 10 milliequivalents per liter loss of potassium. In diarrhea, that can be even 15 to 40, 3 to 4 times, 15 to 40 milliequivalents per liter loss in diarrhea. If the diarrhea for 10 times, what will be the loss? How much potassium is lost? 40 milliequivalents per liter for each stool in diarrhea. 400. Almost up to 300 to 400 milliequivalents per liter loss. So then potassium, how much potassium will decrease in the blood sample? If it is normal is 4, 3.5 to 5. If there is 400 milliequivalents loss of potassium in the stools, so what will be the value? 0.5 to 1. Okay. Generally, what is the total body potassium? Total body potassium is 50 to 55 milliequivalents per kg. So 70 kgs means 3500. The minimum 50 to 55 milliequivalents per kg for 70 kgs means 3500. 98% will be in the cells. 98% is intracellular. That is especially muscle cells. Only 2% is extracellular. So roughly 70 milliequivalents, the total stores is extracellular. In the serum, it is 0.4%. So total serum potassium is around 15 milliequivalents. So it's total potassium. So if you take stool loss, normal it is 5 to 10 milliequivalents per liter loss in normal stool. So in loose stools, it will be 15 to 40 milliequivalents per liter. But if there is diarrhea for 10 times means 400, it can be 300 to 400 milliequivalents per liter loss. Okay. So if you take total body potassium for suppose for 1 milliequivalent decrease, so for one change from 3.5 to 2.5, suppose the baseline is 3.5, it comes to 2.5, that is one change. There will be loss of 200 to 400 milliequivalents of potassium, the total stores. For one increase, there will be addition of 100 to 200 milliequivalents of potassium in the total stores. So we should know total body potassium, total stores, and if the diarrhea is the cause, so how many stools? We should know the actual exact value, at least a value around 300 to 400 milliequivalents, that 10 times loose stools. So vomiting, how it causes potassium loss? What is the normal loss of potassium in vomitings? The expected loss of potassium in vomitings. Suppose in vomiting, how much hydrogen will be lost, how much chloride will be lost, how much potassium. It is not the direct loss of potassium. Vomitings will cause HCl loss. HCl loss means there will be bicarb accumulation, metabolic alkalosis. Vomitings will cause HCl loss and bicarb accumulation. That is metabolic alkalosis. Vomitings will cause metabolic alkalosis. There is more bicarbonate that causes bicarbonaturia. So increased bicarbonate in the distal tubules. That increased bicarbonaturia will cause potassium secretion into the lumen. And with volume loss, with vomitings, with volume loss, there will be secondary hyperaldosteronism. Hypokalemia will cause secondary hyperaldosteronism. The secondary hyperaldosteronism, aldosterone action, sodium retention and potassium secretion. So in vomitings, the main mechanisms are hypokalemia causing increased mineralocorticoid activity, increased aldosterone levels, increased aldosterone causing more potassium secretion in the distal tubule. That is one mechanism. Even bicarbonaturia, increased bicarb levels, bicarbonaturia can cause hypokalemia. Okay, what is the mechanism in Cushing syndrome? Hypokalemia and Cushing syndrome. So increased cortisol in Cushing syndrome. Cortisol has mineralocorticoid activity. So mineralocorticoid that can cause sodium retention and potassium secretion. Even ectopic ACTH, malignancies with ectopic ACTH production, they can cause hypokalemia. Okay. Or if they increase non-reabsorbable anions, any conditions with increased non-reabsorbable anions can cause potassium loss. So we should know the underlying cellular mechanism for potassium secretion into the distal tubule. And what is the underlying cellular mechanism? So what is the normal voltage in the inside the cell? Inside the cell will be around -60 to -70. So in the tubular cell, this is the apical part, apical membrane part. This is basolateral membrane part. This is lumen, apical part and basolateral part. So the mechanism for this negative potential is sodium potassium ATPase activity in the basolateral membrane that is stimulated by aldosterone. The sodium potassium ATPase activity. So sodium, 3 sodium will enter into peritubular capillary, 2 potassium will enter inside the cell. So 3 sodium will enter into peritubular capillaries. 3 sodium will come out of the cell, that causes negative potential, -60. So if there is negative potential, that causes sodium entry into the cell through inoc channels. That is the mechanism. Here it is -60. That causes more sodium entry inside the cell through inoc channels. So there is more sodium entry into the cell. What happens to the potential in lumen? Negative potential. Here it is -70, 0 is negative potential. The negative potential causes increased potassium secretion into the cell, into the lumen. That is the underlying mechanism. So potential difference will cause ion transfers. So we should know all ion channels and exchange mechanisms and underlying electrical potential. Hope you understood the mechanism. So inside the cell, in the basolateral membrane, through sodium potassium ATPase activity, that is by aldosterone activity, 3 sodium will enter into the peritubular capillaries. So there will be negative potential. That negative potential causes sodium entry into the cell. So if more sodium enters inside the cell, here it is there is negative potential in the lumen. That causes potassium secretion. So whenever there are anions, more anions in the cell, negative ions in the cell, like bicarbonaturia, even chloride, there is more chloride or more bicarbonate, or non-reabsorbable anions like penicillins, penicillin derivatives, or antifungal drugs. So any anionic, non-reabsorbable anions are present that causes potassium secretion and hypokalemia. In penicillin, there is varieties of penicillins. Penicillins, naphthalines, dicloxolin, tecarcillin, oxacillin, carbamazepine, all these drugs can cause hypokalemia. Even magnesium deficiency can cause hypokalemia. What is the underlying mechanism? So in the thick part of the ascending limb, the channel is NK2CC channel. NK2CC channel. Sodium absorption, potassium absorption, and chloride absorption. That is NK2CC channel. The other channels are called ROMK channels. ROMK. That is renal outer medullary potassium channels. They cause potassium secretion into the lumen. Potassium secretion into the lumen. So magnesium inhibits ROMK channels. Normally magnesium inhibits ROMK channels. If there is magnesium deficiency, so there is no inhibition of ROMK channels. That causes potassium secretion into the lumen and hypokalemia. That is the mechanism. So apart from ROMK channels, there are big KK channels. The other channels, big KK channels, they also secrete potassium. So they are the underlying important causes of hypokalemia. So other mechanisms in acute myocardial infarction or ischemic cardiomyopathy patient are any patient with acute myocardial infarction, because of increased catecholamine levels, there will be redistribution of potassium into the cells, the shift of potassium into the cells. So that can cause mild hypokalemia. Or patient, acute MI patient has vomitings. That vomitings can cause hypokalemia. If an elderly malnourished patient, decreased intake can cause hypokalemia. Or if we give beta sympathomimetic drugs, methylxanthines, routinely we give theophylline methylxanthines. If patient has pulmonary edema, we will add sympathomimetic drugs also. That can cause hypokalemia. If it is diabetic, if we give insulin, that insulin can cause hypokalemia. Whenever there is hypokalemia, we should check for thyrotoxicosis also. The thyrotoxicosis can cause hypokalemia. So downstream stimulation of sodium potassium ATPase, any condition causing stimulation of sodium potassium ATPase can cause hypokalemia. We should rule out pseudohypokalemia. And then the extrarenal losses. So we should look for GA losses. Then all conditions causing increased mineralocorticoid activity. When patient has shock, that can increase mineralocorticoid activity. Secondary hyperaldosteronism. So increased mineralocorticoid activity, or hypomagnesemia, or if you give penicillin group of drugs or antifungal drugs. So increased non-reabsorbable anions in the distal tubule, that can cause hypokalemia, or vomitings, or nasogastric drainage, diabetic ketoacidosis, lactic acidosis, all can cause hypokalemia. So the approach to hypokalemia, and how do you investigate it? So patient has hypokalemia, normal anion gap, hypokalemia, normal anion gap, metabolic acidosis, urine anion gap is negative. So what is the underlying cause? So hypokalemia, normal anion gap, metabolic acidosis, urine anion gap is negative. So we discussed about hypokalemia causes. So what are the causes of normal anion gap, metabolic acidosis with hypokalemia? Diuria. So whenever for normal anion gap, metabolic acidosis, just remember two important causes. One is diuria, second one is renal tubular acidosis. These two are the important causes of normal anion gap, metabolic acidosis. So with normal anion gap, metabolic acidosis, it could be either diuria or renal tubular acidosis. So then we should check for urine anion gap. Most important, urine anion gap. then we should check for urine osmolar gap. There are other tests to differentiate various causes. So what is the urine anion gap importance? In diarrhea, urine anion gap is negative. In renal tubular acidosis, it is positive. Why it is negative? How do you measure urine anion gap? So basically anion gap is difference between unmeasurable anions and unmeasurable cations. So unmeasurable anions minus unmeasurable cations. But in urine, normal measurable cations are sodium and potassium. Measurable cations are sodium and potassium. Unmeasurable cation is ammonium, NH3. So in the anions, most important is chloride. Measurable anion is chloride. So the difference between measurable cations and measurable anions, so sodium plus potassium minus chloride is urine anion gap. If the urine formula is sodium plus potassium minus chloride. So what happens to ammonia in diarrhea? In diarrhea, there is normal anion gap, metabolic acidosis. There is metabolic acidosis. If there is metabolic acidosis, what happens to urine pH? Urine acidity will increase or decrease? Urine acidity will increase. Means there should be more hydrogen secretion. We expect more hydrogen secretion into the lumen. So there will be more ammonia production. There will be more ammonia production, and so ammonium chloride. There will be increased chloride production also. So there will be increased chloride levels in diarrhea. So increased chloride levels will cause a negative urine anion gap. Okay. So hypokalemia, normal anion gap, metabolic acidosis with urine anion gap negative means that indicates diarrhea. We expect urine anion gap positive in renal tubular acidosis. So hypokalemia, so urine potassium more than 15 millimoles or more than 15 milliequivalents per gram creatinine is urine potassium. Transtubular potassium gradient more than 4, normal BP, metabolic alkalosis, urine chloride more than 20 milliequivalents, urine calcium by creatinine less than 0.15. What is the underlying cause? Hypokalemia, urine potassium more than 15. So there is potassium secretion. So next step is, in hypokalemia case, next step is we should check urine potassium, spot urine potassium. Spot urine potassium is less than 15. If urine potassium is low, what does it indicate? Urine potassium is low means extrarenal loss. So that indicates extrarenal loss. So in extrarenal loss, then check acid-base imbalance. Extrarenal loss with metabolic acidosis. What is the cause? Extrarenal loss, metabolic acidosis means GI loss, bicarb loss. So extrarenal loss with metabolic alkalosis, vomitings, nasogastric drainage, chlorodiuria, or profuse setting. These are the causes for metabolic alkalosis. So here urine potassium is more than 15 to 30 milliequivalents. It indicates potassium secretion in the tubules. Then we should check for transtubular potassium gradient. Transtubular potassium gradient is, we can easily calculate. If we know the urine and serum potassium, urine and serum osmolality. Less than 3 in, if it is less than 3, that indicates an osmotic diuretic process. If it is less than 3, tubular function is normal. That is, hypokalemia is because of osmotic diuresis. If it is more than 3, that indicates tubulopathy. Here it is more than 4. If more than 4 means there is some tubule disorder, some channels are involved in the tubule. Then BP, then we should check BP. If it is BP is high, BP high indicates high aldosterone levels. High BP means increased aldosterone. But BP is high, we should check aldosterone levels. If aldosterone is high, then check renin levels. High aldosterone, high renin. What are the conditions? High aldosterone, high renin. Renal artery stenosis, renin secreting tumor, or malignant hypertension. So there will be increased renin, increased aldosterone, high BP, hypertension, and hypokalemia. Okay. So high aldosterone with decreased renin, high aldosterone with decreased renin means primary hyperaldosteronism. Primary hyperaldosteronism. Main problem is in the adrenal gland. Then renin levels will be low. Then if cortisol is high, aldosterone is low, and cortisol is high. So hypokalemia, urine potassium is more. So more potassium secretion in the tubule. TTKG is more than 4, means there is some tubule disorder. BP, suppose if BP is high, in this case, in this example, BP is normal, but suppose if BP is high, we should look for aldosterone levels. If aldosterone is increased, renin is increased, then renal artery stenosis, renin secreting tumors, and malignant hypertension. Aldosterone high, low renin levels means primary adrenal class, primary hyperaldosteronism. Okay. So high BP, but aldosterone is low, cortisol is high. Cushing syndrome. High BP, aldosterone is low, cortisol is high. High cortisol, because negative feedback on aldosterone levels. So low aldosterone, high cortisol means Cushing syndrome. Low aldosterone, normal cortisol means Liddle syndrome. Same. Syndrome of apparent menulocorticoid excess, Liddle syndrome, licorice, they all act on ENaC channels and sodium potassium ATPase channels. So in those conditions, aldosterone will be low. A negative feedback mechanism. Okay. So this is regarding if BP is high, we should check aldosterone, renin, cortisol levels. Here in this case, BP is normal or low? Normal or low? BP is normal or low, then we should check acid-base disorder. With metabolic acidosis means DKA, RTA, or estezolamide causing proximal RTA or amphotericin drugs. The renal tubular acidosis causes drugs causing renal tubular acidosis. They will cause metabolic acidosis. Or if some variability, we should check for non-reabsorbable anions also, penicillin, hippurates. They can cause a variable acid-base disorder. But here in this case, metabolic alkalosis. Metabolic alkalosis. So if BP is low and there is metabolic alkalosis, then most important is we should check for urine chloride. If urine chloride is less than 10, low urine chloride, what does it indicate? Low urine chloride means vomitings, HCl loss. So urine chloride will be low. But HCl loss will cause hyperaldosteronism, hypovolemia, hyperaldosteronism. Aldosterone will cause sodium retention and potassium and hydrogen secretion. That is, hydrogen secretion will cause metabolic alkalosis. Here, low BP, metabolic alkalosis, and urine chloride, if it is low, that indicates vomitings. chlorodiuria, chloride loss causes. Here urine chloride is more than 20, high. If urine chloride is high, then we should check urine calcium creatinine molar ratio. Urine calcium creatinine molar ratio. So we should check for calciuresis. There is calciuresis. If CaCR molar ratio is low, what does it indicate? If it is high, more than 0.20, what does it indicate? So if you take diuretics, loop diuretics will cause more calciuresis or thiazide diuretics? Loop diuretics. So loop diuretics will be more calciuresis, urine calcium by creatinine ratio will be more than 0.20. In thiazide diuretics, less calciuresis, less than 0.15. Okay? So Bartter syndrome, it behaves like a loop diuretic. The Gittelman syndrome, like thiazide diuretics. So it gives clues that patient might be on thiazide diuretic. So if patient is not on thiazide diuretic, we should look for Gittelman syndrome. Most common is thiazide diuretic condition. So we should check all these parameters. So hypokalemia, first we should check urine potassium. Urine potassium. If urine potassium is low, means extra renal loss. Extra renal loss with metabolic acidosis indicates GI loss, diarrhea. Metabolic acidosis. So metabolic alkalosis means vomitings. Vomitings, nasogastric drainage, chlorodiuria, or profuse sweating. If urine potassium is high, indicates secretion of potassium into the urine, in the tubules. Then check TTKG, transtubular potassium gradient. If it is less than 3, it means a simple osmotic diuresis. Tubule function is normal. All channels, functions, all are normal. Only osmotic diuresis is causing hypokalemia, if TTKG is less than 3. But if it is more than 4, we should look for tubulopathies. Some drugs or diseases involving tubule. So then check BP. If there is hypertension, check aldosterone. If aldosterone is high, renin is high, look for those causes. If aldosterone is high, renin is low, look for primary adrenal gland causes. If aldosterone is low, check cortisol. Cortisol is high, indicate Cushing syndrome. Aldosterone is low, but cortisol is normal or low. Indicates diseases acting on INAC channels, like Liddle syndrome, or same syndrome of apparent mineralocorticoid excess, or licorice, carbamazepine, glyceric acid, glyceretinic acid, or many conditions involving 11-beta dehydrogenase activity. Here patient has, in this example, BP is low, hypovolemia, or even with normal BP. Then check acid-base disorder. Low BP, metabolic acidosis, renal tubular acidosis. DKA, renal tubular acidosis, or drugs causing renal tubular acidosis. Okay. If there is metabolic alkalosis, then check urine chloride. The less urine chloride means chloride loss. Again, vomiting, nasogastric drainage. More urine chloride means, then check calciuresis. Check urine calcium by creatinine molar ratio. If calciuresis is more, means loop diuretic or Bartter syndrome. So less calciuresis, less than 0.15, means thiazide diuretics. So simple thiazide diuretic can give this picture. Okay, thank you.